Hello, I was asked to say a few words about the new ABEM certifying exam. So I'm just going to recap for about the next 10 minutes or so, a lecture that I gave at conference recently. Hopefully, I have a little bit of insider information along with a group of other folks. I was invited to go down to Raleigh, North Carolina to actually take this exam last month. So for faculty members trying to create this exam to give to our residents or residents who want to have a little bit of sort of like background about how the exam is going to roll out. Maybe this will be helpful to you. So let me go ahead and share. All right. So for starters, if you have questions, I really do encourage you to go to the ABEM website, abem.org. That's where all of my visuals are from. I did sign a non-disclosure agreement when I went to Raleigh, so I can speak in general terms about the exam and refer you to information on the website, but obviously I can't give you any specifics about exam cases. What is the new process to become board certified? It's still the same qualifying exam, which was, it used to be known as the written exam. So written exam, qualifying exam, it's the same. And no changes to that thing. That will happen every fall. And then after passing that, usually graduates will go on to take the oral exam, but that is now being retired. And instead, they are having the new certifying exam, which will be starting in March of 2026. And there will be exam times throughout the year, which again, graduates can sign up for. And once you've passed your qualifying or written exam and your certifying, which is again taking the place of the oral exam, you are ABEM certified. How is this different? I think the biggest thing that ABEM talks about is that the certifying exam is much more broad. It talks about additional competencies that aren't traditionally examined. So lots of cases about communications, and that can be both, as it says here on the slide, high stakes communications, difficult conversations, and then there are procedural cases, which again are completely new compared with the old style oral boards. So you will go in and actually take an exam where you have to do a procedure on a task trainer and explain the steps, explain, the indications and sort of how you're going to perform the procedure and potentially aftercare after the procedure is performed. This also includes ultrasound cases where the applicant will be performing ultrasounds on a hired, actor. So actually doing ultrasounds on a human. And then there are other clinical cases. And so this again is things like, trying to diagnose a clinical situation. And especially the thing that's new and different is this concept of prioritization. So cases that have to do with prioritizing which patient you might see first. But these are the sort of like the competencies here on the slide that they're trying to get after. And then this is how they're actually going to do it. So first of all, everyone goes to Raleigh. Everyone from around the country is going to be coming down to Raleigh, North Carolina. There are half-day sessions, and everybody's going to be plugged into one of these sessions. It takes place at actually a large assessment center, which that includes, simulation rooms, but it's a big assessment center used by other specialties already. So it's not a brand new thing. It's right next to this Hyatt House Hotel, which is actually the hotel sort of like that's the ground zero for the exam. And, tip number one is try, if you're a resident listening to this, get a hotel room at this Hyatt House, because this is the most convenient way to actually, sort of go through the whole process. You actually meet the morning of the exam in this hotel in one of the conference rooms. They talk you through what's going to happen, and then they walk you over behind there. You actually see this assessment center. They walk you over there and get you going, but you're basically under supervision the entire time after you sort of signed in the morning of the exam. They do take away they don't take away your phones. They basically ask you to put your phones in a bag, and so you're not going to have any kind of sort of personal effects when you go to the simulation center, except if you want to hold on to a purse or valuables, there are lockers at the simulation center that you will lock everything up in. And then they keep your luggage at, the hotel, and it's super convenient. It's definitely very secure, felt very comfortable with it. But again, when you go to the simulation center, you are no longer going to be able to do any recording or photos or anything like that. So I don't have any photos of the inside of that assessment center. I will say, though, it looks suspiciously like something on the set of Severance. There are these big, long hallways, and the hallways have, a number of examination rooms, and each examination room has a chair outside of it, and it's labeled with a number. So it's a little ominous feeling, and you sort of have to sort of like, sort of settle into that concept. You're assigned a chair that you're going to be sitting at, and they'll tell you where to go. It's all extremely regulated. They make it very straightforward in that they give you tons of instructions and information. In fact, becomes a little bit repetitive, but you are not going to be like wandering the halls or going around and doing what you want to do. You're not exploring. You're going to be sort of stuck in your seat, and then you're going to go to your case, and then you're going to come back, and then you're going to repeat and sort of go throughout the morning like that. So that's sort of the actual, like, how the exam's going to roll out for the day. Once you're done, of course, you go back to the Hyatt, you get your luggage, and then you're free to go at that point. What are the actual cases that describe the different competencies that ABEM is looking to examine? These are then the actual cases that the case, basically the types of cases that you'll be exposed to if you're an applicant here. First of all, they're either 15 or 10-minute cases. The clinical care cases are 15 minutes. The communications are 10 minutes. I found that this was plenty of time, more than enough time, all the way through the morning. And so I think, again, as long as you've done some preparation and done some of these mock, exams, I think all of our graduates are going to be extremely well prepared to complete these exams in well under the time that's given. The clinical care cases, again, are probably the things you're going to be most sort of like just somewhere most familiar. The cases will have examiners in the room with you, and again, they're going to be taking you through either a clinical decision-making case where you actually have to, again, work through, actual case and solve, an unknown, or you'll have a prioritization case. And this prioritization case is not meant to get to the final sort of be-all, end-all diagnosis for all of these different cases that are on a tracking board. But the prioritization case's purpose is to actually assess, are you able to figure out which patient needs to be seen first or second or third based on limited information and based on your ability to ask for specifics, that would happen just like we would do in the emergency department in real time, right away, to be able to say, okay, wait a minute, no, I can go see this other patient first. This patient can wait. No, this patient can't wait. That's what they're basically trying to get at with a prioritization case. So again, that's four cases, basically two of these clinical decision-making cases, two of these prioritization cases. The other six cases are communication cases or procedure cases. And the procedure cases, again, are either going to be you doing a procedure on a task trainer with an examiner in the room, or there will be again, a hired actor who is going to be the patient that you're doing ultrasounds on. And in both cases, again, you're going to have an examiner in the room, and they're going to be sort of like telling you what they want you to say or to do. The procedure case, you're going to actually, sort of talk about the setup for it, do the procedure, talk about the aftercare. The ultrasound is interesting because you're going to actually obtain images, and the examiner is going to sort of run the machine. So you don't need to know the beyond all about the actual machine, but you do need to ask for, I don't know, like improved, depth or a better gain. And so you can give those kind of requests to the examiner, and they will operate the machine for you. You will then obtain images. You'll usually have to describe what you're actually seeing, maybe what's normal, what's abnormal. And then they'll flash up like an ideal image and ask you to interpret that. So those are the ultrasound procedure cases. And then the other communication cases are what you see there in the bottom bullet points. So these, reassessment, difficult conversation, managing conflict, and patient-centered communications should all be sort of familiar concepts. These will all be with standardized patient actors, and you will not necessarily have an examiner in the room with you. You're just going to be you and this standardized patient actor, and you'll have a scenario ahead of time that you'll be able to read through, and then you go into the room, and then you go ahead and have the conversation with that standardized patient actor. Again, I think these are all things that we can really work on to make sure our residents are well prepared for and are ready for. I think the communication stuff is probably the most maybe intuitive, but it's not without need for preparation as well, because these are somewhat nuanced conversations, and you're going to be scored on how well you can actually in the moment have potentially a difficult conversation with a patient. So, as far as like what ultrasounds and what procedures are up for grabs for this is all from the website again. I would say you go to the website and look, because it's a little bit like, wow, this is a lot of ultrasounds that they could test you on, and wow, look at all those procedures. And I think that some of these things are very straightforward, and you're like, okay, great, things like doing a paracentesis. You could certainly figure out how to do that fairly, in a fairly straightforward way in a task trainer, and that's an easy, probably pretty easy assessment to do. But there are things that we very, very rarely do, umbilical line catheter or something like that. And those are still things that are potentially up for grabs as far as procedure. And so you have to be ready to do really anything that are on these lists. So I would definitely, for the residents in the room, take a look at the procedures, take a look at the ultrasounds, and at some level, you should be ready to demonstrate proficiency in everything that are on these lists. How about sort of rules of the game? You will get some information before every single case. Either, and this is what I found, it's like on the website and it's down in Raleigh, the examiner will read you something if it's the clinical case or the prioritization case. They also talk about, giving you actually one of these pieces of paper with like this, sort of like scenario on it. But actually both on the videos that are on the ABEM website and what I encountered in Raleigh, you don't actually get anything to read for the clinical cases or the prioritization cases. You're simply receiving instructions verbally from the examiner. But this again is on the ABEM website, good to look at ahead of time. And again, they also have videos of sort of like um, good examples of these different types of cases on the ABEM website. So that's another place to go to get more information. And then, of course, the big deal, how are these things scored? Well, who knows? So this is very much a black box. The screenshots that I have here are directly from the abem.org website. I think there are sort of like things that are pretty obvious that they're going to be looking for as far as these are what you should have to do in order to do well, for example, in the prioritization case or on this clinical decision-making case. But what is actually going to be worth a certain amount of points? Are there going to be like, things that like basically critical actions that if you miss them, you fail the case? What's going to be a passing score? We do not know the answer to those questions. I don't know that ABEM is going to release that information. So I think all you can do really is think about what you need to do in real life to do, to basically, either prioritize care for multiple patients or to go through a clinical case and make a correct diagnosis and, practice with what we are, providing as far as resources and look at those videos on the ABEM website. And that's going to be probably all the information you're going to have with regards to scoring. I will say again, there is a lot more than simply getting the answer, getting the case correct. It's a lot more than just making the diagnosis for these clinical decision-making cases. You are going to be asked about, a differential. You're going to be asked about what kind of evaluation you would want to do. You're going to be asked about what kind of counseling you would give a patient or family at the end of the case, how you're going to actually do the handoff. Transitions of care are very important, and that's all going to be examined. So it's not simply going to be, oh, I got the case and therefore I'm done. There are these other pieces that are being examined. And so again, the best you can to know the rules of the game so you can win the game, well, take a look at the website, take a look at these bullet point lists, and that's again, probably the best information we have to give you. So again, for my tips for the residents in the room, go back to that ABEM website. There's good sample videos. There are debrief videos. Those are separate. Those are actually saying, like what went well, what could go better. It is an intimidating process. I found that even, knowing that this didn't matter at all to me, it wasn't going to affect my board certification. It was still a fairly anxiety-provoking morning. So, you gotta again sort of like be as prepared as you can so that the game part of it doesn't throw you too much. I know that the RLT is going to be doing a ton of work to help you all get prepared. So anything that they label or signal as, hey, this is something that will be an ABEM prep session, try to be there for that. When examiners are asking questions, just make sure you're answering the question that's being asked and provide all the information that you know. I think that's always a good rule of thumb, just like the old oral boards. If you know the answer to a question or you know information, they are going to be seeing how you interpret data. They're going to be asking, like how you're working through something mentally, and so you have to verbalize that so that they can sort of see inside your brain and know what your thinking process is. If you do like, if you're not sure what someone said, or you're like, wait, what was that? Totally okay to ask an examiner to repeat anything. You can also totally ask for a minute to think. Again, you're going to have plenty of time for this. So if you're like, whoa, wait a minute, I just need a second, just ask for that minute. That's not going to be held against you. And as I said, you're unlikely to run out of time, so be deliberate, be careful. This is your last high stakes exam that you're going to take. So you do want to make sure that you're super well prepared. And then when you go into it, be very deliberate with the whole process. I will say there are far fewer, I guess, prompts than you would expect. And I'm going to flash through a few slides here just to give you examples of a clinical case and our prioritization case. When we used to do the old oral boards, there was all these, like stimuli and, tons of information. And this is not the case, not that kind of case. They're going to ask you questions. You're going to respond with your answers. But it's not going to be it's not going to be like you can just keep asking more questions. It's all driven by the examiner. It's not driven by you. It's going to be them asking you a question, you responding. If there's something else for you to see as far as an X-ray finding or whatnot, great, but there may not be. And that's just all the information you get. And those are the last 2 points there. So let me just say a couple of words about each of these two types of cases that I think are probably sort of the new and more challenging kinds of cases. Again, the prioritization case, the way it's going to unfold is they're going to give you some kind of basically a deck of patients like this. And the way that it rolls out is you'll get this amount of information initially, a chief complaint and some vital signs. And it's going to be very scripted. The examiner will ask you, basically for 2 or 3 pieces of information that you would want to know about each of these patients in order for you to help prioritize which patient you should see first. And again, this could be, pieces of history that you might want to know, or physical exam findings that would be easy to pull out, or initial immediately available diagnostic testing. So that could be, point of care testing. That could be, I want to order an X-ray. And it could be, I want to order a CT. You're obviously not going to get that back right away. But it's that idea that if you had a bunch of patients on your tracking board and you're just trying to go boom, 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 who do I need to see first? What information about each of these patients do would help me make that prioritization decision? And again, I think you need to look at vital signs very carefully, see what the oxygenation is doing and how much oxygen somebody's on. Just being very cognizant in your own mind, building sort of like a most likely idea of what this patient might look like. And then again, your initial 2 or 3 pieces of information that you're asking for from the examiner is going to basically be to fill in some gaps to really let you make a decision about who you need to see first. Once you've actually said those, 2 or 3 items of information that you want to the examiner, they'll give you a new tracking board. And that new tracking board now will have, basically this condition report or some pieces of information. Now, they're not going to be the pieces of information that you asked for necessarily, but it's going to be more information. And this should then further be able to help you decide, who do I need to go see first? Because now you should be able to be like, okay, I know what's going on with this patient. Are they unstable? Are they stable? And remember, what they're really going to be going after, this was pretty obvious, is, they want you to go see the patient with a life threat first. probably the limb threat second. And I would fall back to your ABCs if you're trying to figure out two potential life threats. It's going to be like an airway breathing problem first. See that patient before you see a patient with a circulation problem. And I think that's pretty clear again off the videos that are on the website. So this already sort of lets you see, like sort of like this is the whole picture. This is what you got. And anytime this says a stimulus is available here, there's like a chest X-ray available down here, there's a knee X-ray available, you can just go ahead and say, give me all the stimuli. And that's totally fair. And that shows up on the video. And I would do that because you need all of the information you can get. And they'll flash those stimuli up and you'll be able to take a look at them. After you get all of this information, then the next step is going to be that the examiner will actually say, okay, well, who do you want to go see first? And it's not going to just be who do you want to see first, but of course it's, why and what immediate stabilizing treatment would you want to perform? And I think if you looked at this tracking board, I think we'd all say, okay, this is a patient with an airway issue. And so this is the patient I'd see first, and I'd see them first because they look like they have a life-threatening airway issue. And my immediate stabilization would be to intubate the patient. That would be like how that might play. And you could add on and I'd order additional CAT scans or whatever else to a point, but they just want to know, like, in the moment, in that first sort of a first initial encounter with that patient, what are you going to immediately do to stabilize the patient? So for that patient, it's going to be an intubation. And then after that, they're going to ask you another question. And this is really important. What they're going to ask you is while you're stabilizing this patient, so like they're basically saying, like, as you're intubating this patient here with this airway catastrophe, motorcycle crash, are there any tasks that you'd like to delegate to your care team to do for another patient? And what I would say at that moment is I'd go back through the whole, tracking board, all the way through all these other patients. I'd say, is there anything I could get a nurse or a tech or someone to do for me, And so, maybe it's going to be, draw up medication, pain medicine for this patient, who has a knee injury. Maybe it's going to be, check and do some IV fluids on someone who needs IV fluids. I mean, it could be anything you can think of that a nurse or tech or someone in your team, maybe someone with asthma, I'd want respiratory therapy to give, get a med neb started. It's that idea of what do we do in real life to help sort of temporize, to save some time, and to use our resources, our team, to help us move more quickly through a large bolus of patients. Just think about that bolus sliding. What am I going to have my teammate do to sort of keep the ball rolling on this? And I'll say the other recording I made was with Andrew Tashney, and I totally forgot to do this step. So that won't happen on that recording, but in real life or in the real exam, yeah, just listen for that extra question from the examiner, and that's going to be, hey, what do you want your care team to do while you're doing the initial stabilization of your most critically ill patient? In this case, while you're intubating this patient. And after that, they'll just say, hey, okay, great, you stabilize that patient. Now, who do you want to stabilize next? And they'll do that a couple more times. Then they'll basically ask you, to stabilize the next couple of patients. Again, why are you choosing the next patient? What are you going to do for that initial stabilization for that patient? And then the curveball is going to be that they're going to say, okay, you stabilized the first three patients, but before you could do anything else, they're going to throw a couple more patients at you. And they're going to say, while you were waiting, or while you were like doing your, ongoing stabilization of everybody, a couple more patients arrive, and they'll be at the bottom of the board. And these will be patients who may be less or more sick than the remaining patients that you still need to see from the original tracking board. And in this case, we made this patient down here somebody with a big pneumothorax, and they obviously are hypoxic. So the correct answer would be, after you've seen those first three of the initial patients, your fourth patient is actually one of the new patients. It might not be. It might be your fourth patient should be someone from your initial group of six, but they're going to ask you to choose a fourth patient, say why, say what your initial stabilization will be, and then that's going to be the end of that case. So that's that one. And then the other one is this clinical decision-making case. And this, I think, is even more straightforward because, again, this is going to be basically solve the case, right? They're going to give you an admitting form. The examiner is going to ask you to read through it, and then they're going to ask you to basically ask whatever historical questions that you want to ask. And my big my big sort of recommendation on this one is do just that. Ask all of the historical questions, the HPI that you would want to know from a patient with a similar chief complaint in the emergency department. Yeah, don't necessarily ask something that's completely irrelevant, but any sort of HPI, review of systems, past history, past surgical history, that's all stuff that you would want to verbalize, to the examiner. And then after that, they're going to ask you to say that, okay, what now on a physical exam would you be looking for? And you want to be specific. So not just like, I'm going to do an abdominal exam, but again, just like we did in the old-fashioned oral boards, I want to, look at their abdomen, and then I want to listen to their abdomen. I'm going to press all the quadrants. So do they have surgical findings or not? Are there any masses? What does the skin look like? So you do that degree of specificity because they're asking to basically examine how well you can perform a physical. After that, there will be some more information given to you. So they'll feed this back to you. And again, this may be things that you asked for. There may be things on here that you didn't ask for, but so read it carefully because this is now helping you hone in on what the diagnosis is. And you're going to take a look at the history, you're going to take a look at the physical exam findings. And at that point, they'll say, okay, great. Now based on what you know, what are the top three items in your differential diagnosis? And you really just should give them those three. Don't try to give them four or five because they're going to take the first three, and that's what that's what you're providing. Again, answer the question that is asked. So if they ask for three diagnoses, give them three potential diagnoses, and think about it for a second because this matters a lot. You want to make sure that your first diagnosis is the one that is most likely, and then you want to give them two other, probable diagnoses. And then after that, they'll ask you to perform diagnostic testing, and you can again do lab testing, blood, urine, certainly any imaging that you want. All of that, should be ordered. They will probably throw in there. This shows up on the videos. It showed up, basically as part of this exam or this kind of a case, a general question that doesn't necessarily have anything to do with this case specifically. And this is sort of similar to, like the pathophysiology points that, you used to get on the old oral board. So they'll just ask some general, you know, exam type question about, a similar presentation, but not necessarily this specific case. So don't let that throw you. Again, they're just testing your medical knowledge, and just answer the question. Then they will give you all of the workup that not necessarily again that you asked for, but they'll give you the workup that has been done on that patient. And based on this, you'll take a moment and then they'll say, what treatment or actions would you like to take for your patient? And this makes sense. You're just rolling through this like you would a regular case. Now, what am I going to do for interventions as far as, am I going to treat pain? Am I going to give IV fluids? Am I going to make them NPO? Am I going to call a consultant? All of that stuff would be, actions that you would take to care for the patient. And they're doing this in a very deliberate sequence of questions. So even if you said, well, I would have given this patient pain medicine, 10 minutes ago, don't worry about that. They're just answer the question that's given. And at this time, this is when they're going to ask you, what do you want to do to take care of your patient? And again, they may or may not throw another additional general question somewhere in here about, general care of a patient with, I don't know, in this case, like abdominal pain. And then they'll say the patient's been stabilized, and they'll ask you what you might be communicating with with the patient and with a family member about what you think is going on at this point. Again, they're testing, your communication skills. This is a time that you would be, using, more sort of like layman's terms as far as the information you're providing, but you're not role playing, you're not pretending you're talking to the patient. You're just saying like, oh, I'll tell the patient I'm thinking this is the problem. I'm thinking this is what we're going to do to help you out. These are the next steps, that kind of thing. And then they're going to formally ask you for the final diagnosis, and you're going to give that. And then the last piece will be that, they'll say, okay, you've decided to, in this case, admit the patient. When transitioning care to the admitting physician, what information would you convey to to that physician. Again, this is all about the importance of a handoff. If this was a patient who was going home, they would say something like, okay, what instructions would you provide to the patient? And again, that's all of that sort of like expectant, management and what they should come back for and what's their follow-up, all that kind of stuff. So if they're going home, just think about it in terms of a really good set of discharge instructions. And then that's it. So, those are the two cases again that I think are the the sort of the ones that you'll run into that are maybe a little more unusual, a prioritization case, and then that, the clinical decision-making case. And again, if you have any questions, make sure you go on back to the abem.org website. And if you have anything that you want to hear about as far as my trip to Raleigh, I'm happy to again answer in broad strokes as much as I'm able, again, given the non-disclosure agreement. Hope that's helpful. Take care. Bye-bye.